Okay, well, I'm going to talk a little bit about our experience teaching anesthesia in Ghana. And just to hook us all in, surgery and surgeons and anesthesiologists are sort of a team now, and we really work together well, and we're partners in our efforts in global health as well. Ghana is a very interesting country. It is a constitutional democracy. It has a president, vice president, cabinet, parliament, and a Supreme Court justice system. It also has 10 regions that are spread out all over, and in those 10 regions are 25 million people. And this is just one of the lineup of school children before they march into class, and it's quite exciting to listen to the music, and then they trot off to their various classes. I'll give you a little overview of a brief history of the anesthetic practice in Ghana as it is today, the philosophy and sustainability of a collaborative anesthetic education program, and then politics and problems, what is our role, and the goals for 2012. Well, in 1987, the UK, in conjunction with Dr. Gabriel Boakye and Frank Bonney, restructured the operating room at the KATH Hospital in Kumasi, Ghana, and started a nurse anesthesia program. Currently, there are 590 nurse anesthetists in Ghana, a teaching hospital, 4 teaching hospitals, 2 new ones, one in Cape Coast and one in Tamale. And there are 10 regional hospitals, 230 district hospitals, military, organizational, church, and NGO hospitals. The burden of anesthesia care, as it is in most of Africa, is taken on by the nurse anesthetists. Certification, registration, and licensing recently was placed under the Medical and Dental Council in Ghana. Gabriel was the only anesthesiologist at the KATH until about 2009, so he represented the only anesthesiologist in West Africa. They have limited resources, machines, ventilators, monitors, supplies, medications, and with some private hospital exceptions. There's a high infant and maternal mortality. There is a breakthrough at the Ridge Hospital with Dr. Midge Owen and her Cabelli group, significantly reducing infant and maternal mortality with a wonderful program. Major problems for public health. We've heard them all: water, typhoid, non-covered sewers, malaria, transportation and roads. And road accidents are the #1 cause of mortality and morbidity in Ghana. A visionary CEO sent Ghanaian MDs for residency training in anesthesiology and other specialties, and produced what we might call a reverse brain drain. Currently, there are 5 anesthesiologists now at the KATH Hospital in Kumasi. They have developed a very wonderful nurse anesthesia school for all these years. It's an 18-month program. They take graduate nurses who've been out in practice for 3 years, either in an ICU or in a ward or in an emergency room, and they come to the KATH school for an 18-month program. And they currently have classes now over 50 every year, and as I said, a large number practicing in Ghana. There's also, excitingly, a very new anesthesia residency program with some very, very smart residents, and we're really totally excited about that. And finally, we have a medical student anesthesia interest group. As you know, medical education is a 6-year program, and then 2 years of housemanship, and then 2 years of national service. And then we're praying that these people will come back and do a subspecialty, a 5-year program in anesthesiology. The philosophy, under the direction of our Ghanaian colleagues, we assist in the teaching and the nurse anesthetists and the residents, basic science and clinical anesthesia. We also participate in the OR teaching and the clinical care, providing textbooks, lectures, demonstrations, such as regional blocks, fiber optic innovations, echocardiography, and then the annual KATH anesthesia refresher course. We're in our 9th one this year, and nurse anesthetists come from all over Ghana, some travel as much as 12 hours one way to participate in this 2-day program. And this is just illustrating one of our, some of our senior residents. We hit the ground. They knew we were there. Immediately they said, hey, bring your needles and bupivacaine. They had 2 gentlemen that were T-boned in a taxi. One of them broke his right humerus. The other one broke his left humerus, and within 10 minutes, they're in the operating room using ultrasound-guided surgical block, the only one in Africa, the only machine they had in Africa. And that's Dr. Steve Oppany there, unfortunately, one of the most outstanding orthopedic surgeons who's now the head of the FDA in Ghana. Too bad. We also teach a few other little technologies. The echo has been very good. There's no way to measure pressure, get central pressure or any kind of indication of volume. We can, in 30 seconds, put a little echo on the chest and get an idea of volume status. As you would imagine, it's always low. Okay, what about sustainability? Well, I want to echo what Dr. Schechter said. Long-term collaborative relationship and friendships with exchanges. Continued teaching presence. When I go to Ghana, I don't sightsee. In 13 years, I think I've been to the slave castle for 2 hours. The rest of the time, I'm in the operating room or in the classroom teaching. So I think that is where we see what is actually being done, what the problems are. We develop these relationships with all the staff. We know all the technical people, the people that work in the operating room, that do the surgery, that clean the floors, and we help with that. And we learn about all the problems and the conditions, and both pre-op and post-op, okay? We started out with yearly visits, we went to biannual visits, and now we're spending up to 2 months a year on the ground, and this is going to increase even more. So year-round planning, continued communication, and interactions. I receive 2 or 3 emails a day back and forth from Africa. We're planning our refresher courses, how we're going to teach, what we're going to do. So it's a constant, continuous process. Here's our annual refresher course, a lecture being given by Dr. Scott Provost a number of years ago. We try to deal with the problems that are there. We always have a lecture in trauma. We talk about OB, pediatrics, and we try to deal with the diseases that are there. We also teach around that aspect. This is Dr. Gabriel Boakye and Dr. Gladys Amponsah, the so-called mother and father of anesthesia in Ghana, and Dr. Boakye is presenting a lecture at the refresher course. And this is another important area, neonatal resuscitation. This lecture was given by one of our residents, Raul, and Rustin, and exciting. You can see everybody's taking notes, everybody's interested, and he presented some great concepts which they deal with every day. And here is a picture of Dr. Scott Junkins a number of years ago presenting a certificate to Abiba, one of the nurse anesthetists. Right next to Scott is Dr. Gabriel Boakye, who will be stepping down this year, and hopefully the man next to him on the left, Dr. Kwame Antikusi, will be taking over, an exciting young man, and he's got a lot of plans ahead for the anesthesia program in Ghana. And of course, teaching is so important. So we spend many, many hours a day teaching and then going into the OR in the afternoon and the night and on the weekends. And what we do is we have each student. I start a lecture with each student presenting a case. For instance, a month ago, we had a patient with a pressure of 240 over 130. The student presented that, and then we talked about hypertension and the physiology and anatomy and how to take care of that patient. And that's why we're there. This is the class of 2012, 54 students who leave their families, their children, to come and pay their way in Kumasi to spend 18 months learning how to become nurse anesthetists. Politics and problems. A new election, there's a new party, there's a new hospital CEO and a board. It's unfortunate, there's no transfer. Visionary and non-visionary CEOs. Affordable resources that aren't available. High infant maternal mortality. Unnecessary deaths because of lack of monitors, ventilators, and consumables. Some medications we're learning cost more in Ghana than in the US. OR management and efficiency. OB patients overload. On the weekends, the district hospitals close. They all stream into the main teaching hospital in Kumasi. It's a tremendous overload, lack of space. Neonatal resuscitation is not the greatest. Prolonged periods of time before the patient reaches the hospital. There's no beds available after surgery. The patients can't pay their bill. They're put on the floor. The medicine patients are on the floor. The surgery patients stay in their bed until they can pay their bill. There's a delayed care of all the patients that come from the ER. And there's minimal M&M quality assurance programs to sort of learn from past problems. Here's the new A&E Recovery Room. The previous CEO was able to build have an $80 million accident emergency center built. They have a wonderful recovery room. The problem is they don't have any resources or consumables. And here's where all the work is done in the main theater. You can see how crowded it is. There's too many patients and no space. The lady on the right had a typhoid perforation. She'll be there for 3 or 4 days because there's no room in the hospital. They have a very nice protocol, triple antibiotic therapy and fluids. And then when you finish with the child, and you have to make sure that the power is working in the recovery room, that the incubator's working, that there's oxygen, and that everything's set up before you go in. You don't want to leave the OR unless you know that is ready to go. There's my friend Beatrice. And then when you get to the one incubator and you make sure it's working, many times with these small babies, they're going to lose heat. So we have to keep them intubated until we get them warmed up, and then we can extubate them. This is last month, in 1 week, we had 3 giant ruptured omphalocele, and you would imagine the mortality is very, very high. The problem is the surgery went beautifully, the anesthesia went beautifully, the patient was awake and breathing, 100% saturation, but with that big weight on the abdomen and no other technology, no ventilator, that type of thing, it becomes a very difficult situation in terms of keeping that child alive. But many of these patients come through very nicely, and we see 4 little babies in a bed. I think the baby in the middle there was a baby that was 8 hours old that I took care of for a mesenteric fistula, and the surgeon did a beautiful job, and that baby did very well. And then we have the post-op and pre-op, and you can see on the left with my friend Alfredo, that little guy was just so sick with ruptured typhoid, and he was lying there febrile, hyperdynamic. We walk in the room, and the word for white guy and is called obrudi. And this little guy, as sick as he was, he saw the 2 of us, and he was lying there just so sick. He jumps up, his eyes go big and wide. He says, "Oh, Bruni!" And we just loved this guy, and he did very, very well. He finally made it. He was still very sick at that point. On the other side is a child with a Wilms tumor. Most of his body is tumor, and these are the kinds of things that come in this late, but we try to do the best we can under the circumstances. This is just a little bit to show we've done some surveys to figure out what the monitors are and what the equipment is, and you can see there that they now have pulse oximetry. It started back in 2000, and about 70% have that. And there's no capnograms. If I was going to have one monitor, I think I'd take the end-tidal CO2. I think I could use that and know more about the patient than any one monitor. If I had the best of all worlds, I'd have an oximeter and an end-tidal CO2. We try a little experiment. We got these little finger pulse oximeters that run on 2 AAA batteries. I think I've bought about 600 of them. And we've had no failures. We did a year test. We had about 150 out, no failures. And they're using them. And they seem to be working out. They have a 2-year warranty, and I've got a little deal going with the Concord Health people, and they're down to $22 a unit. There are other wonderful systems out there. LifeBox has a wonderful technology, but it's $250, so that's the problem. We've got to find something that's of lower cost where they can be everywhere. So these are all over Ghana now, and we'll be distributing them again at the refresher course as part of the registration. We used to have a 3-bed ICU right next to the recovery room. Those machines have gone down. We now have a brand new event ventilator that was there in November, but they had no consumables. Got home, called the company in California, and I learned last week that they now have the consumables. Same for medications. Ketamine is the key drug in all developing countries, and we're seeing advances in terms of opioid and pain management. Okay, what about OB pain management? Very minimal. There's a lack of qualified staff and resources. They were using Demerol for some patients. Most of the patients at the KATH have no post-operative pain management. At the Ridge Hospital, Dr. Midge Owen is using single-shot spinals during the early parts of labor, and that seems to be helping. This is a talk I was going to give 3 years ago. I still haven't given it. I hope this year that we'll be able to start doing more epidurals in labor for the patients at the KATH Hospital. What is our role? I think it is to identify our dedicated faculty and support their efforts. Give and take interaction has occurred over all these years, and always the final decision is by our host. We maintain discussion of conditions and possible solutions. Unfortunately, on Monday at the KATH Hospital, which is the biggest hospital, second biggest hospital in Ghana, the junior faculty and then the senior faculty went on strike. The conditions are so severe that they couldn't safely take care of their patients. They're still on strike. The Minister of Health is speaking to them as we speak, trying to get them to go back and take care of patients. We always must provide our standard of care. We must promote exchange of faculty, residents, and medical students. And this is what our plan is for this year and beyond. We have a consortium of anesthesia departments here in the U.S., and we have the KATH Hospital. We're going to get together and obtain a 5-year teaching grant to include an anesthesia teaching lab and simulator at the KATH. And we also have a countrywide and regional hospital education program. We've done some preliminary work with this, using site visits to show the Ministry of Health that they need to have these resources and also to standardize the practice throughout Ghana. We're going to do that in conjunction with the Ministry of Health so that we can have the same standard of care, same monitors, and same medications throughout the country. Our goal, healthy Ghanaians, okay? That's what our goal is. We want to strive for that. And thank you all for your attention.